Hi, everyone. Good afternoon. Welcome to Lowcountry Autism Foundation's Community Conversations. We are doing Facebook Live today. I am Sophia Towns. I'm the program coordinator for the Lowcountry Autism Foundation. And today we have a very special guest joining us. DeLynn Morgan is from the South Carolina Department of Mental Health. And we are going to be discussing mental health resources throughout the Lowcountry today. And we're going to focus on two main topics. The first being, what do you do when you and your loved one are in crisis? In other words, you feel that your loved one with autism, or they don't necessarily need to have autism, if you feel that they are a danger to themselves or to others, what are the steps that you need to take? And what are some of the resources offered in the state of South Carolina, and especially in the Lowcountry, to deal with that? And then the second topic we're going to talk about is mental health resources in general. How do we access that when we either do not have insurance, when we have Medicaid, or if the insurance that we do have does not cover mental health services? So there are options for some of us out there. So DeLynn, I'm going to turn it over to you. And we're just so excited for you to join us today. This is a really important topic, and just through our daily work at Lowcountry Autism Foundation, we do see quite a number of families that are struggling right now with their loved one. And they need help, and they need more resources for when their loved one becomes aggressive. So if you could tell us what you can offer our families.
Absolutely. Hello, everyone. I am housed at our Charleston and Dorchester office in the Lowcountry. I oversee our local mobile crisis team. I also oversee our statewide call center. So if someone is calling in crisis during or after business hours, it comes to a team of clinicians that take the initial call, and then they will forward it to whatever county the mobile crisis clinicians that call is coming from. So mobile crisis is a team of clinicians that assess patients who are in crisis. It could be someone who is having suicidal thoughts, someone who is psychotic, or someone who is threatening harm towards someone. So it could be someone with autism that is aggressive or having a meltdown, and they cannot be kind of de-escalated within the family. If you're able to get your loved one into the mental health center during business hours, those mobile crisis clinicians are housed in the local mental health center, whichever county you live in. After hours, we always have 2 mobile crisis clinicians on call. Now, the mobile crisis team in our Charleston area, we have been in practice for about 35 years now. But about 3 years ago, our state director mandated that every county in the state of South Carolina have some form of mobile crisis. So that is statewide. And the coastal region is where we started first. So every county in the whole coastal region has a mobile crisis team. So there is a 1-800, well, it's a 1-800 number, but it's 833. I'm going to give that out to you guys quickly. It's 833-364-2274. Now, during business hours, I recommend that you call your mental health center directly, because if you call this number during business hours, they're going to get a little bit of information from you, but they're going to forward that call to the mobile crisis clinician at that local mental health center. So calling the mental health center directly would just be quicker access to services. After hours, you can call this number, and whoever answers that would be the ones dispatching the team out to you. So the team would come out to your house if you cannot get your loved one into the mental health center, and they would do a psychiatric evaluation. They are going to ask you several questions on what kind of behaviors are going on, what kind of symptoms are going on. They're going to try to ask the patient questions, and they're going to be looking for safety. They're going to be trying to come up with a safety plan. These teams were created to keep patients out of psychiatric hospitals, but if we cannot de-escalate it, we cannot come up with a safety plan. This team has the ability to complete emergency commitment papers and get the patients to a psychiatric facility or to a local emergency room. Emergency rooms may not be able to provide treatment, but they can provide a safe place until your loved one can calm down and the threat of harm goes away. So this team does always respond with law enforcement. We get a lot of people that say, we don't want to call police, we just want to call you guys. We just want the clinicians to come. For safety reasons, anytime mobile clinicians come out into the community to assess someone, they always have a police officer meet them on scene. Just for our safety and for the patient's safety. NAMI, I'm sure you guys have heard of the National Alliance of the Mentally Ill. They do trainings all over the state. They do 40-hour trainings with law enforcement. I participate in all of the ones in Charleston and Dorchester County, really trying to educate these police officers on de-escalation techniques, active listening skills. A lot of times police departments will send these crisis interventionally trained police officers to scenes such as this, but they do have to respond. And then if patients are placed on emergency commitment papers, the police are the ones that transport the patients to the hospital. That process, after hours, the mobile crisis clinicians are coming from their homes. They try their best to get there within 30 minutes, but depending on where they're traveling from, it can take up to an hour. If there is threat of harm immediately, we always recommend that you call 911 just to get someone there within minutes to provide safety until the mobile crisis clinicians can get there. So sometimes we will make that recommendation just to get them there faster. Sophia talked about kind of some local mental health services for care providers, for family members. All of the mental health centers can provide that care. All of the mental health centers take Medicaid. And if someone does not have insurance, all mental health centers offer a hardship reduction. In order to qualify for that, you do have to show proof of what your household income is. But most of our patients qualify for the maximum reduction, and they end up paying $5 a service. Whether they're seeing the doctor, whether they're seeing the counselor, whether it's a group session, it goes all the way down to $5 a service. They treat depression, they treat anxiety. With regards to autism, autism is not a diagnosis that the mental health center would treat if it stands alone. But if the person also has depression or also has anxiety or also has bipolar disorder, then we will treat both pieces. We just won't treat autism if it stands alone. Any questions about what that emergency assessment looks like, Any questions?
Yeah, I think if you don't mind just kind of going through what an assessment, an emergency assessment may look like.
Yeah, so again, we come in pairs, so always 2 clinicians come in. They might separate where one's talking to family and one's trying to talk to the patient. They're going to ask questions about what's currently going on, what symptoms and behaviors are you currently experiencing. They're going to ask questions about what stressors are going on that's kind of resulted in this. They're going to ask questions about history, history of treatment, history of aggression, history of hospitalizations, any medications that may be involved. They will ask some medical questions. They will ask about substance use. And then they'll ask a lot about support systems. Again, we try really hard not to send people to the hospitals. So like if there's a grandparent that lives down the street or an aunt or an uncle that lives close by, that maybe we can bring in as a support for a night or two, just to give a little bit of separation while things calm down. So they're going to ask questions about the support system, and then they'll ask questions about the patient's willingness for treatment. So in order for someone to meet criteria, legal criteria for emergency commitment papers to be done, there has to be imminent risk of harm due to suicidality, homicidality, or psychosis. There has to be an unwillingness for the appropriate level of care. And there has to be an inability to create a safety plan. So sometimes we see patients that really need hospitalization to provide immediate safety, but they're not willing for that. But they are willing to come into our mental health center the next day or 2 days later. But that's not an appropriate level of care in that moment to ensure safety. So we look at, again, imminence of harm, willingness for the appropriate level of treatment, and the ability to create a safety plan or the availability of a support system. And with support systems, although patients may have very loving, caring, supportive family members, if that patient's anger or paranoia is directed at those family members, in that moment, we cannot use those family members as a support system because that's who their anger and paranoia is directed towards. So saying that they can't be the safety plan and the support system in that moment does not equate with they don't have a loving, caring family. So we will ask those questions. Usually the clinicians will step away. The 2 of them will kind of talk about what has been heard and what has been seen. And they will talk about what appropriate dispositions they think may work. We always have an administrator on call. They will also call that administrator and staff with that administrator. So we will have 3 people, 3 professionals talking about what's happening, what are the risks, what are the possible dispositions, and they will decide what they think the best plan of action is. They will keep law enforcement informed during that process on what's happening. If they decide to do the emergency commitment papers, they will complete those papers, there while they're on scene. They will contact a probate court judge, talk it over with that judge, and if the judge agrees, he or she will issue an order of detention that will allow law enforcement to take the patient into custody and transport to a psychiatric facility or to an emergency department.
Okay.
The mobile crisis clinicians will, talk the families through how to get to the hospital, how to follow the law enforcement, or make sure they have phone numbers to the hospitals as well. The mobile crisis clinicians will also, on the next day, follow up. So if the patients do go to a hospital, the mobile crisis clinicians will be calling the hospital the next day to determine what happened there. And if the patients are returned home, they will be calling the family back just to make sure everything is all right.
Okay. Do you think that it's better to call the mobile crisis unit after hours versus the family trying to get the patient in the car and driving them directly to the emergency room?
It's a good question. I always prefer the least invasive method.
Mm-hmm.
So when mobile crisis comes, again, they do bring law enforcement. So I certainly understand when families do not want police rolling up to their house. Sometimes just because we've called police out, an EMS ambulance may show up as well. So that can be invasive. If the family feels that they can get the patient to the emergency room safely,
Mm-hmm.
then that is a good option. The people in the emergency room can do the same evaluation that the mobile crisis team can do.
Mm-hmm.
But if the patient has a history of trying to jump out of the car or trying to grab the steering wheel or kicking whoever's driving the car, then I recommend calling mobile crisis out.
Okay. Okay. Because I have been dealing with some families lately who they themselves got their loved one to the ER. They sit in the ER, and then at that point, by the time they can be assessed, they have de-escalated.
Right.
But there's still a problem there that hasn't really been addressed. And then the individual is discharged and they're back home. And the next day, here they go again. So
and we see that same situation just with children that we see, like kids with ADHD or oppositional defiant disorder. A lot of times we get them to the hospital. Once they calm down, the hospital discharges them back home, and then the school's calling us the next day because the same thing has happened. We used to be pretty successful in getting direct admissions into like MUSC,
right,
or Palmetto here in the Charleston area. With COVID, that has put a barrier up. MUSC's not taking any direct admissions. All the patients have to go through the emergency room to be screened for COVID. And MUSC is really the only game in town that take the younger kids, 6 to 12. But yeah, you're right. Once, 2 hours go by, 3 hours go by, patient falls asleep, they're usually sending them back home.
Yeah. We do have a question here. If an individual does not have a formal diagnosis of depression or another comorbid diagnosis with autism spectrum disorder, but it is suspected, can they be seen? So do they
Absolutely.
have to have that formal diagnosis of the depression, of the anxiety, or is that something that you can assist with at the mental health centers in the counties?
Yeah. So emergently, there doesn't even have to be a hint of that second diagnosis. The mobile crisis clinicians will respond emergently to just the autism diagnosis. If they're wanting to get treatment for depression, for anxiety, then absolutely, the mental health center would do a formal, pretty lengthy, most of the initial assessments at the mental health centers take about an hour and a half to 2 hours to assess for those diagnoses.
Okay.
So if
So
you
they can,
suspect that, then absolutely
yeah.
they can come in and be assessed.
Okay, that's great to know. Wow. I think just by educating our families out there today on the resources that exist, but we just don't know about. I mean, this
Right.
is huge. I had no idea a couple of weeks ago before you and I spoke on the phone. This is
Right.
amazing. You know, just I'm so happy to know all of this information.
And just to bring some reassurance, that CIT training that I mentioned to you,
yes,
that we do for the law enforcement,
yes,
they bring someone in that speaks just to autism. So the police are not just getting training on mental illness and that side. They are getting specific training around autism as well.
Sure. And I think actually one of our Dr. Stacy Litton, one of our LAF staff members, actually she does a lot of the police training for NAMI for autism. So we're really proud to have her on our team. So yeah, it's the more we educate, the better.
Absolutely.
For everyone, the better for everyone.
Absolutely.
Yes, absolutely. I do have one question about when you're doing the assessment. The mobile crisis unit is over with a family, and you mentioned that there has to be certain criteria for you all to get involved to get that individual to a safe place. And one of them was one of the criteria, I think, was willingness. So that's willingness on the side of the patient, or is that okay? Because if it's a teenager, how does that play?
Yeah, willing for a teenager, it would be willingness of the parents and the child. So we've been in front of a 14-year-old who is willing to go to the hospital, wants to go to the hospital. The 14-year-old is refusing to do any kind of contract for safety, but parents do not want the child in the hospital. So the parents' unwillingness has led us to do those papers in order to get that child to a safe place. Our hope is that we could arrange it voluntarily, because we certainly don't want to put a child through that commitment process if we can avoid it. But there have been times that we've had to for safety reasons. Sure.
So you can actually, if the child, you clearly see the child needs the commitment papers, but mom and dad or the caregiver, the guardian is against it, you guys can actually override that and get that child what he or she needs.
Yes.
Okay.
Because that child temporarily will go into law enforcement's custody.
Gotcha.
And be taken to the hospital.
Okay.
If the child went voluntarily, then the parents would have to sign permission at the hospital and give consent. The commitment papers would allow the child to be admitted without that parental consent. Okay.
That's good to know. You worry about that sometimes, unfortunately.
Sure. Yeah.
Very sad. But I'm glad to hear that you guys can actually override that and get that child what he or she needs. Um, wow. I'm just amazed at the work that you guys do. This is absolutely amazing. Let's see. As far as locating your mental health center, where would those be located?
Well, there's one in every county. So like for Hilton Head, Beaufort, Jasper, Hampton, all of those are under the Coastal Empire Mental Health Center.
Okay.
I believe, so they could just Google Coastal Empire Mental Health Center. And
Okay.
then there should be separate clinics in each county.
Okay.
But they're all under Coastal Empire. The Myrtle Beach area, they're all under Waccamaw Mental Health Center, but they have different clinics, like one in Conway, one in Georgetown, I think one in Myrtle Beach, but they're all under the title Waccamaw Mental Health Center.
Gotcha.
So they should be able, they can just Google it and it would tell them the address and the direct phone number to it. And again, that number I gave you guys at the beginning, that could get them there too. It just is going to get transferred a couple times during business hours.
Okay. Okay. That 833-364-2274, correct?
Correct.
Okay. Okay.
Yes. And then the mental health centers are open Monday through Friday from 8:30 to 5.
Okay.
I know in the Charleston and Dorchester area, we see people with scheduled appointments and with walk-ins, but not all mental health centers operate like that. Everyone can walk in emergently, but if you're going to do that initial assessment to get connected to treatment, you may want to call ahead and schedule.
Okay. Okay. All right. And what ages do you see at the mental health centers? Is there a minimum age?
We've seen them as young as 2 before. Now, obviously, with the little itty bitty ones, the clinicians will be doing more work with the parents, more around parenting skills and behavior modification and that kind of stuff. But we see them, and we now have a MDFT. It's a multidisciplinary family therapy. It's a team that comes together that does just kind of consulting, doing consultation services for people with the young ones, with a lot of behavioral stuff going on. But we see them starting at age 2 and all the way up, 80s, 90s,
Awesome.
the whole range.
Awesome.
We have a lot of clinicians who are embedded in the schools now too.
Wow.
So for kids who we're seeing a lot of the symptoms and behaviors in the school setting, it's really helpful to have their clinician there on site to kind of help resolve that when it's happening. And a lot of times it's easier for the family members to get to a session at the school as opposed to all the way into wherever the mental health center is located.
Okay. So would you contact the school first, maybe, to see if...
you can do either. You can contact the school and they can connect you with that clinician, or you could call the mental health center and say which school your child's in. And then they could make that connection.
That's awesome. I had no idea about that. That's amazing. Wow. So many amazing things today. Well, guys, I think that's all we have for today, unless there was anything else you wanted to add, DeLynn.
Yeah, thank you guys for all that you do. Thank you for being our partners and
Absolutely.
And working together. It takes a team for sure.
Absolutely. Absolutely. Guys, please post any more questions in the comment section, and we will do our very best to get those answered. And just stay tuned. We're going to do another community conversations next week. So, and we'll have a counselor as our special guest. So some really good, empowering information for our families. Thank you so much, DeLynn.
You're welcome.
Okay.
Thank you, guys.
Thank you. Bye, everyone.